Good afternoon, everybody. At the outset, let me thank the organizers for inviting me for this talk. We'll be looking at the concept of neuroplasticity and neuroregeneration in stroke and how best we can apply these to treat stroke patients better. For many years, it was thought that the brain was a non-renewable organ and that we are born with a definite number of neurons which we can use it till we die. But it was the father of neurology, Santiago Ramon y Cajal, who coined the term neuroplasticity. And he described non-pathological changes in the structure of adult brain. So to understand these three terms, one, neuroplasticity means there are formation of new neural connections. When we talk about neuroregeneration, we means there is repair of nervous tissue going on, and neurogenesis means formation of new neurons from neural stem cell or progenitor cells. So when a brain has any injury, all these three processes comes into play, and they are interlinked. And compared to the previous concept, now we know that the restorative window is much longer. Coming to neuroplasticity, basically we have neuroplasticity going inside our brain every day because of our interaction with our environment. So the simple explanation is, suppose you are using your dartboard and practicing throwing darts. After a few days or few weeks, you'll see that you have improved and you can aim at the bullseye better. So what is happening here is your premotor and the supplementary motor cortex is sending more signals, more specific signals to the motor cortex, which is making you hit the target better. And this boils down all the way to the neuronal level. So basically here what's happening is the Hebbian concept, which states that cells which fire together, wire together. And this happens because of modification of dendritic spine, which some of which grow and connect with the nearby dendrites. And also there are some pruning also happening of unwanted connections. And at a more cellular level, there is long-term potentiation and long-term depression going on to bring on this effect. Now, when you look at a stroke brain, this goes one step more, and the functional borders becomes blurred. So if you look at this cartoon, you have this red colored area which is doing a function A, and the green colored area which is doing a function B. Following the stroke, there is a new area which is developing in between this, in colored yellow, which has function of both these areas. So this is something which is happening post-stroke, which is going beyond the normal plasticity which we all have. Neuroregeneration. This is the zebrafish, and if you cut the spine of this zebrafish, within few weeks it can regrow and become totally functionally normal. And this is Christopher Reeve, Superman, who had a riding injury and who injured his spine, and in spite of the best medical treatment, he never recovered. So there is a difference of long distance axonal regeneration and functional recovery when you compare early vertebrates like fish and salamanders, and this is very poor in man and other mammals. So surprisingly, if you believe in evolution, if you look at the evolution, so there is something has gone wrong, and the humans are not able to regenerate. So is that a benefit or not? The explanation for this is human brain is much more complex, than the brain of a fish, and adding any new neurons may be dangerous. It can cause confusion to the whole network, and also it can cause inappropriate electrical activity and short circuiting and cause things like seizures. But even here, there is some difference between the peripheral nervous system and the central nervous system. The peripheral nervous system has facilitators which stimulate plasticity and neuro regeneration, whereas the central nervous system has brakes which limits this plasticity. So these brakes, what are these brakes and facilitators? There are a lot of intrinsic and extrinsic factors, mainly chemicals and other hormones and other neuropeptides, which acts as brakes and accelerators. Now, lastly, we look at adult neurogenesis. So here we have neural progenitor cells, which is residing in the subventricular zone lining the lateral ventricles, and also the dentate gyri of the hippocampus. And if stimulated, they can produce new cells. In fact, this is happening to us every day. And by the time we reach our adult life, most of these neurons in these areas are already replaced by new neurons. Now, how can we apply this information for stroke patients? One is medications. One of the medications which has been extensively studied is fluoxetine. The FLAME trial, which conducted this trial, showed if you give 3 months of oral fluoxetine with 20 milligrams per day, there was remarkable improvement in recovery, especially in motor functions. But however, pooled analysis of more than around 7,000 patients from 9 randomized controlled trials showed there was definite improvement in the Fugl-Meyer motor scale, also Barthel index, and also even in the NIHS. But however, fluoxetine did not change the proportion of patients achieving a MRS of less than 2. And also note that fluoxetine is not without risk. It can cause hyponatremia, seizures, etc. Amphetamine was another drug which came up in a big way, but the last trial conducted on this was the STARS trial, which did not show benefit. Dopaminergic drugs are the next group of drugs which are being investigated, which can help in motor recovery of stroke. Growth factors has been tried, and these growth factors, what it does is it stimulates the neural progenitor cells. The 2 human trials which has looked at this was the regenesis trial and the BETAS trial. In these trials, they use beta-HCG and human erythropoietin in acute stroke patients to stimulate the neural progenitor cells. But however, these trials were negative. Monoclonal antibodies can be used mainly to target the brakes, which is impeding neuroplasticity and regeneration, especially inside the CNS. These are the factors which has been targeted to neutralize these molecules which inhibits growth and to produce a more permissible growth environment for the damaged brain. Brain stimulation is a thing which has been carried out currently in many centers. There are many types of brain stimulation, but the main stimulation which is being tried is the transcranial magnetic stimulation and the transcranial direct current stimulation. TCCD is very simple, where you transfer a small current, that is 1 to 2 milliampules, into the cortical tissue. So if you put the anode over the motor cortex, you can excite the tissue, and placing cathode over the motor cortex, you can inhibit. Improvement in motor controls were seen when excitatory stimuli was given to the affected hemisphere and inhibitory stimuli given to the contralateral hemisphere. So this is one area where studies are being shown consistently to have good reports. Post-stroke aphasia is especially benefited by this intervention. Repetitive transcranial magnetic stimulation is similar, where you use magnets to stimulate the brain. High frequency stimulation can excitate and low frequency can inhibit. So RTMS has been, over the motor cortex, has been shown to reduce spasticity and hemiparesis, improve the grasping function, and it is to be noted that this treatment has to be given within the first 1 month following the stroke to have a benefit. However, a recent Cochrane review does not support the routine use of this therapy after stroke. But what we should realize is all these meta-analyses are heterogeneous. There is heterogeneity of patients, that is patients having cortical versus subcortical, ischemic versus hemorrhagic, the timing, the number of pulses, number of sessions, intensity of current use, duration, whether rehabilitation and was being concomitantly used, and sham stimulation was also done. All these are not uniform. So the last word on this stimulative therapy is not yet said. What about activity-based therapies? These are simple things. This is based on a concept called learned non-use. That is, a stroke survivor usually relies on the non-paretic hand and arm for their daily activities. And each time he does it, this encourages the paralyzed arm, the recovery is being slowed down. So this is the concept of learned non-use. So one of the therapies we can easily do is the constraint-induced movement therapy, where you restrain the non-affected limb in order to overcome this learned disuse of the affected hand. The second one is the mirror therapy, where the patient views through the mirror the good limb as the paralyzed limb, and this is known to increase plasticity. Lastly, we have the stem cell-based therapies. Stem cells, what we should realize is when you give stem cell therapy, it's not only that we are trying to achieve new neurons, but it has multiple benefits like angiogenesis, synaptogenesis, even anti-inflammatory effects and white matter remodeling. So in preclinical studies, mesenchymal stem cells has consistently shown to have good results, as you can see from this meta-analysis. However, when it comes to human stem cell trials, there is no proven benefit yet, but there are trials which is still ongoing. A new thing which has come is the use of exosomes. As we see, when you look at the stroke brain, you have the penumbra and the infarct core. And what you should know is the necrotic core dies by necrosis, whereas the penumbra dies by what you call as apoptosis. So when this apoptosis happens, it releases bodies called the exosomes into the circulation. And initially it was thought that these exosomes are just garbage bags, which is used by the cells to throw out their unwanted things. But these exosomes contains important proteins, lipids, nucleic acids, etc., which is known to be beneficial effect. They can induce angiogenesis. They can be immunomodulatory. They can cause neuroprotective effect and even lysis of thrombus. So there are a lot of studies which is looking at the exosomes for stroke treatment. And one trial is being done in Iran in Isfahan University of Medical Sciences. Supposed to be completed by the end of this year. So in brief, we can say that treatment to promote neuronal repair after stroke is a rapidly expanding field. Most trials currently focus on a single agent or intervention. Combination therapy are likely to receive increased attention. It's important that stages of stroke, because some of these therapies are known to affect certain stages, and we should tailor it accordingly. And knowledge and understanding is important, especially for stroke neurologists, to get patients into clinical trials. Thank you.